Well, good evening, everybody, and welcome to the Global Health Celebration. The theme of the Congress is Better Together, and there's no place that's better demonstrated than in global health. It's my pleasure. I'm Veena Nadkarni, newly the president of the SCCM, and it's really a great pleasure to be here tonight and to really introduce to you again John Sampson, the host for tonight's event, who's going to really lead the celebration. The things that we're going to talk about tonight a little more intensively are a couple of new initiatives. They're not the only initiatives, but they're the new initiatives. And let me tell you just a little bit about John. Not a lot, just a little. John is an associate professor at the Johns Hopkins University in anesthesiology and critical care medicine. And he's really the founder of an amazing program at Johns Hopkins, the Global Alliance of Perioperative Professionals, or the GAP program, which is not filling the gap, I guess, not really creating anything. Dr. Sampson is from here. He's a native Californian, and he went to school at UCSF at the School of Medicine, and he then did his residency and training on the East Coast. But he taught and practiced medicine in many countries, including Africa, the Caribbean, right, and India. And his first experience, as I understand it, I think during medical school, was in Nigeria. And so he has had a career and a lifetime of experience in global health, and you'll hear and sense that. But currently, he's leading the SCCM African Infrastructure Relief and Support Program that you heard a little bit about, or you heard mentioned this morning, or the AIRS project, and it's really an amazing program. And so, John, I'm just going to turn it over to you and let you sort of take the evening away. But thanks, everybody, for coming. It's really, it's good to see old friends and make new ones. John.
Welcome. So today we're going to have this program's really divided into three sections. The first section, I'm going to tell you a little bit about what the new SCCM Global Health Initiative is. What are the components of it? Then second portion of our program, we're going to feature leading global health critical care physicians that are part of the Society of Critical Care Medicine, physicians and nurses that are part of the Society of Critical Care Medicine in the fields of internal medicine, surgery and trauma surgery, pediatrics, anesthesia, and nursing. And then the third portion is our environmentally friendly portion, where we're going to feature innovative technologies for global health that are environmentally friendly. This program is also co-hosted by the G4 Alliance, and in a few moments I'm going to introduce our moderator, who is the chief of the advisory director for the G4 Alliance, which is a global surgery, obstetric, trauma, and anesthesia organization. That's what the 4 of G4 is, surgery, obstetric, trauma, and anesthesia, which Paul Farmer, an internal medicine doctor, and the considered to be the father of global health, considers surgery as the forgotten stepchild of global health simply because of its lack of support entirely amongst different countries that have almost no surgical support at all. First, the first thing I'd like to do is to talk a little bit about the Ukraine program. And the Ukraine program, one of the leaders of the Ukraine program is Jose Diaz Gomez. And I would like Jose to stand up. Be recognized? There you go, okay? And Jose, could you come up and just tell a little bit about this amazing program, which is a result of a generous donation from Direct Relief to the Society of Critical Care Medicine? Jose.
Thank you, John. So it has been probably the most distinct privilege in my career to lead a team of 10 individuals that are going to Ukraine. It's a diverse group. There are nurse practitioners, there are anesthesiologists, internists, people from private practice, from academia, 10 of us. We will deliver a high quality content, will be translated to the Ukrainian language. We even will be able to offer an advanced course for those train the trainer, and we have a plan to really even measure the impact long term, how this train the trainer will become even investigators, people that we can learn from. So lastly, I will say that the SCCM staff, including Teresa Wiki, Colleen McNamara, of course, Marlene Hurt, and our CEO, David Martin, have been extremely supportive and very meticulous how this mission needs to be delivered. Don't worry, we'll be safe. We're gonna be in a bombshell. And the people who authorized me to go, the first one were my two kids. They say, Dad, you are an American citizen. You must support the Ukrainians. And my wife said, they are right. So thank you so much for your support.
Thank you. Thank you, Jose. All right, and then just a moment, it's just a little bit of a video explainer that we're going to watch that sort of highlights what the Africa Infrastructure Relief and Support Program, which is called the SCCM AIRS program, is about. And in addition to the Ukraine program, the AIRS program is another portion of what is being developed into SCCM Global Health. Are we ready for the, you give me the signal. Okay, good.
Oxygen. Life as we know it is not possible without oxygen. Our bodies are designed to bring oxygen from the atmosphere and to distribute it to tissues throughout the entire body. When injury or disease interrupts this normal process, tissues are damaged, muscles are damaged, vital organs damaged, and ultimately, death will take place. Hospitals around the world have systems that support the delivery of oxygen to expectant mothers, newborn babies, trauma and surgical patients, and any other patients who may need oxygen for their survival. Healthcare providers in developed systems utilize oxygen routinely and often take for granted that they have an unlimited supply by way of the simple turn of the knob of a flow meter or the push of a button. The World Health Organization has even officially declared oxygen as the most essential medicine for which there is no substitute. However, there are many parts of the world where a reliable supply of medical oxygen is simply unavailable, resulting in the unnecessary death of laboring mothers, children with pneumonia, medical patients with neurological conditions, patients in need of surgery, patients with survivable traumatic injuries, and/or other critical care illness. This year, the Society of Critical Care Medicine and their partners from Direct Relief will be working with the Johns Hopkins Global Alliance of Perioperative Professionals to sustainably change this healthcare disparity. Starting with the development of hospital-based oxygen infrastructure and renewable energy across major medical centers in 3 African countries that have severe shortages of medical oxygen. This effort will be aided by contributions from Ghana and the African diaspora, which is now described as the 6th region of Africa by the Africa Union. Basic healthcare cannot take place in the absence of oxygen and stable energy. Quality maternal and child health cannot take place in the absence of oxygen and stable energy. Healthcare training cannot take place in the absence of oxygen and stable energy. Efforts to improve oxygen level monitoring through pulse oximetry have limited impact if oxygen is unavailable to give. Advances in medical care cannot take place in the absence of oxygen and stable energy. This initiative of the Society of Critical Care Medicine Global Health is known as the African Infrastructure Relief and Support Initiative, or SCCM AIRS Initiative, and will start with the Gambia, Liberia, and Sierra Leone. We hope that you will feel uplifted by the impact that this program will have on the survival and health of the thousands of people who will benefit. Please join this effort and help us to expand this program across other areas of equal need through your generous support of SCCM Global Health.
Okay. Thank you. So that's basically an overview of the program. The biggest components of it relate to oxygen, access to oxygen, and renewable energy. Would you believe that when we contacted the Ministry of Health and Physician Authorities in the Gambia, would you believe that when we contacted the Ministry of Health Authorities and leaders of the medical community of the Gambia, we found out that up until last year, they were using industrial oxygen for medical purposes because of a lack of medical oxygen. The major teaching hospital in the entire country, a 600-bed hospital, did not have access to system-wide oxygen. So the effect of this on patients is dramatic. This is not the only country that's like that. There are many countries that are like that, but this is key. And so we also found that there are other locations where there is a problem with sustainable energy. The hospital that we're going to be working with in Liberia, we wanted to quantitate how many hours per week they had power outages at the hospital. And for this underserved area of Liberia, the answer we got was the reverse, that they actually have access to power about 2 hours per day. So how are they going to make oxygen if they don't have a stabilization of their energy in the hospital? And therefore, a renewable energy component is part of this. On the other hand, if you have an oxygen system for oxygen generation, you have renewable energy, perhaps solar, then isn't it going to just break down in a year? The answer will be yes, if you don't shore up the biomedical technicians and the maintenance culture. And so an entire component of this particular program is devoted towards making sure that the biomedical engineers are up to grade in terms of their maintenance of oxygen generation equipment as well as renewable energy equipment, and that there is a ongoing maintenance plan for sustainability within this entire program. And so the Society of Critical Care Heirs program also includes training with the FCCS course and also helping other people within the region gain membership of the Society of Critical Care Medicine. So that's pretty much what the beginning of SCCM Global Health is. And if I wouldn't mind asking for a round of applause for the SCCM for starting SCCM Global Health. So the third component of our program, after we feature the different critical care leaders in global health, we're going to feature the three innovations, technological innovations in global health that are environmentally friendly. That'll be the last portion. So at this point, I'd just like to make one moment. I'm probably gonna make this person mad, but I just wanted to acknowledge one of my mentors who helped me in terms of getting on the track for global health, who, when I was at Howard University Hospital, Dr. Haile Muskevi. Thank you. Okay. All right, so now I'm going to introduce our moderator for today, who is the Director of Advisory for the G4 Alliance. And she's going to first tell you a little bit about the G4 Alliance. Natalie, there you are. Okay. Natalie Schienemann.
A little shorter than you. Hi, everyone. Good evening. My name is Natalie Schienemann, and I'm joining you representing the Global Alliance for Surgical, Obstetric, Trauma, and Anesthesia Care, which is known for short as the G4 Alliance. The G4 Alliance is delighted to be co-hosting tonight's event, and we feel very honored to be present at the launch of the exciting new global health initiative of the Society of Critical Care Medicine. Thank you to Dr. Sampson, who's on our board of directors, for bringing us all together today, and to David Martin and Mark Lenhart at SCCM for allowing us to put on an event with a truly astonishing number of brilliant presenters. We hope that in the future there are many more opportunities for us to collaborate. So today I'm thrilled to have the role of guiding us through an esteemed panel of global health professionals, highlighting the diversity of this field and the links between global health work happening in critical care and a broad range of other specialty and subspecialty areas. And then after that, as Dr. Sampson mentioned, we'll be hearing from four additional presenters on sustainable and cost-effective technologies for global health. I will be taking advantage of my moderator's privilege and starting us off with an introduction to global surgery and the G4 Alliance. But first, some housekeeping. We are about to perform an amazing feat of 12 presentations in an hour and a half. I promise all of them will be interesting and engaging, but we're going to hold all questions until the end, and then during the networking, you'll have plenty of time to chat and ask questions to our in-person speakers. And now, I will just start my presentation. I wonder if I'm supposed to pull it up. All right. So my role is the advocacy manager for the G4 Alliance. We are a coalition of 80 nonprofits, professional societies and federations, universities and academic centers, and other civil society organizations dedicated to a mission of advocacy for the neglected surgical patient. But who is the neglected surgical patient? The G4 Alliance is advocating for the 17 million people who die each year because of conditions that could have been prevented or treated with surgery, and the many millions more who suffer from preventable disabilities or face catastrophic health expenditure from seeking necessary care. These include people in countries from all income levels, but the vast majority are people living in the lowest income countries, where 9 out of 10 people do not have access to safe, timely, and affordable care. And these are statistics that are really only estimates, and in fact, they are from the Lancet Commission on Global Surgery, which was published in 2015, which indicates a few things. First, that we don't have very precise global data. And in many cases, especially in low and middle income countries, there isn't very reliable or comprehensive national or local data either on surgical system performance and the gaps between surgeries happening and the surgeries that are needed. Second, there is strong evidence that the backlog of surgical procedures, again, especially in low and middle income countries, has only grown during the last 3 years of the COVID-19 pandemic. So the G4 Alliance is the leading voice advocating for greater prioritization and investment in strengthening of systems for surgical, obstetric, trauma, and anesthesia care. As a coalition, we are able to pool our resources, our networks, which include the highest levels of government, as well as grassroots community leaders, a wide range of skills and expertise coming from our members, and the power of our collective commitment. Our vision is universally available, accessible, acceptable, and quality emergency and essential surgical, obstetric, trauma, and anesthesia care. We organize and focus our goals and strategies around 3 advocacy pillars. Awareness, meaning building awareness of the need, gap, and capacity for surgical, obstetric, trauma, and anesthesia care through a united civil society voice. Policy, specifically creating an enabling environment by leading civil society to develop and promote policies in collaboration with governments and other stakeholders. And finally, resource mobilization, involving growing, aligning, and optimizing resources for surgical system strengthening. Our theory of change is that by mobilizing civil society to build awareness, secure commitments, and create mechanisms of action, we can support and sustain accountable, government-led systems that provide universal access to care. Our membership body is our permanent council, and each of our member organizations has one representative on our permanent council. And the permanent council has formed 17 different working groups to pursue advocacy priorities within our broad goals. So these groups build tools and resources, they create and advance policies, and they conduct research. They do outreach and form partnerships within their focus areas. And a big activity of theirs is knowledge sharing. They organize regular webinars, and many of these are open to the public. Our Innovations in Technology Working Group, which is led by Dr. Sampson, is responsible for inviting many of our technologies presenters today. So I wanted to just close by sharing a few concrete examples of our planned activities for this year that are relevant to critical care, since that's the audience today. In April, we're planning a side event at the World Bank Group and International Monetary Fund spring meetings, where we're inviting national leaders in anesthesia and critical care who will be presenting evidence from the front line of the COVID-19 response, making the case that financing for surgical systems should be part of the new World Bank Pandemic Fund. The fund should include things like training, retaining and sustaining the workforce, and strengthening surgical, anesthesia, and critical care infrastructure. This is part of a longer campaign of the G4 Alliance to demonstrate that investments in surgical systems are a cost-effective way to promote health security, system strengthening, and resilience. And the G4 Alliance is excited because we were recently granted special consultative status with the United Nations Economic and Social Council, which is the main organ of the UN system for NGOs to interact. So we're looking forward to sending a delegation to some upcoming meetings, including a meeting on science, technology, and innovation for the Sustainable Development Goals. And then later in the year, we're going to be engaging at some UN high-level meetings on universal health coverage and pandemic prevention, preparedness, and response. In 2023, we'll also be following developments of a new resolution by member states of the World Health Organization, focusing on emergency, critical, and operative care and universal health coverage. And we're anticipating that this resolution may go before the World Health Assembly this spring. And we're also prioritizing national and grassroots advocacy, including partnering with our members to help scale the impacts of their work through advocacy. And we'd love to continue to collaborate with SCCM Global Health on future advocacy opportunities like that. So thank you for your time, everyone. And if you're interested in learning more about the G4 Alliance and our work, you can find me later today, or you can send me an email. And with that, thank you. With that, I'll speedily move us through our presenters. So I'd like to next introduce Dr. Janice Zimmerman, who is the immediate past president of the World Federation of Intensive and Critical Care. She is a master of the American College of Physicians and Society of Critical Care Medicine, and a fellow of the Royal College of Physicians. So please welcome Dr. Zimmerman. Thank you. I'll just pull up your presentation. Here we go.
Thank you very much for that kind introduction. It's a pleasure to be here and help support Dr. Sampson. And what he asked me to do was to kind of talk about how critical care ties into global health. And it's not a topic you can look up and find literature or a lot of science there, but as I kind of thought through this, I think we have been in global health, we just didn't know it, we didn't call it that. But I'll try to give you some examples of what I think are important aspects of critical care and global health. I thought I'd start with a definition of global health, and this is one by Copeland, which is often used. And I think you'll see some of critical care in here. It says global health is an area of study, research, and practice. We do that in critical care, that places a priority on improving health. We do that. And we hopefully also are trying to achieve equity and health for all people worldwide. And you'll notice a lot of these phrases are found in the mission statements of not only SCCM's mission statement, but a lot of critical care organizations. And you'll see that they emphasize transnational health issues, determinants, and solutions, and I think we are headed in that direction very well. I think the next bullet is really identifies us. We involve many disciplines and we're interdisciplinary, and I think critical care has led the way in multidisciplinary and interdisciplinary patient care. And then synthesis of population-based prevention with individual level care. And we're still working on that, I think, as we move forward. Many people have asked, what is the role of critical care in global health? And I like this pyramid, and you may say, well, it should be the other way around, but I think this is more appropriate. Certainly, global health starts with primary prevention of diseases, the use of immunization, clean water supplies, adequate nutrition. And as people get sick, they end up in the hospital, and that's that emergency and hospital-based care. But some of those people will develop life-threatening issues that require critical care. So critical care is a very important part of any healthcare system and any system when we're looking at global health. However, I think we have to be a little more broad in our concept of what critical care is. We typically think of it as our ICUs here in the US, but it's really an organized system for providing care to critically ill patients. And it might look like this ICU in Sierra Leone when I went with Dr. Sampson. Doesn't look at all like ours, does it? Or it might even be on the ward in a public hospital in El Salvador where critical care is being delivered, but it's not in an ICU. So as having 8 years of service with the World Federation of Intensive and Critical Care, we had the opportunity to ask our member organizations and also groups of physicians and nurses from low and middle income countries, what did they need? In other words, we asked them, what help would you ask for from us? And we consistently got the same answers. It was build research capacity, education, and it was education for all the members of the ICU team and patient care guidelines. So I'd like to go through these three aspects and tell you how I think we are already working in these areas, and certainly it's areas where we can do more. Now, for research capacity, they would like to participate in research trials that are ongoing, but even more than that, they want the research skills so they can address the issues that they face in their own environments. And as we know, the issues they face are not the same ones that we're doing randomized controlled trials on in many cases. And part of that is data collection and management, but it's not just for research that they need that capacity for data collection, but it's also just to describe who their patients are, you know, what diseases they're treating, what the outcomes are, just basic things that we kind of take for granted. But here again, I think we've made an impact in global health, and I think the COVID pandemic has really brought this out. As you know, there have been several global initiatives for collecting data, ICERIC, and also with INFACT, SCCM's Discovery Virus COVID-19 Registry. The COVID trials have become more global. The REMAP-CAP, led by John Marshall and a lot of his colleagues, is involving 25 countries, 300 sites. And also with INFACT, they have developed a basic research course that has now been delivered in Pakistan and in Ethiopia, and as well as in Australia and Hong Kong. So they're acting as mentors to individuals from low and middle income countries to help develop those research skills. Now, global critical care education is where I have to declare my conflict of interest. Because with FCCS, I was one of the original developers, along with Robert Taylor and Phil Dellinger 30 years ago. So I am biased, I'll admit that. But we didn't develop it for global purposes, but it very quickly found a niche in the international sector, our first course being in 1997, because it addresses the basics. And it's now been held in 77 countries, and there's a whole family of FCCS specialties, pediatrics, crisis management, obstetrics, surgical, and resource limited. I also want to mention the basic course, which is developed through Charles Gomersall out of the Chinese University of Hong Kong. And it also addresses basics, a little more advanced, their original course. It's been held in over 70 countries, but they also now have a family of products that addresses needs for nurses, pediatrics, low resource, and they even have what is called very basic. And I haven't seen the content on that one yet, but again, it's getting to education that's needed in resource-limited areas. Many of you may not have yet heard of Essential Emergency and Critical Care, EECC, and this is being promoted by a group from Sweden and Tanzania, Tim Baker, and the World Federation helps support their efforts in developing what we would hope to be a minimum standard of care. And the goal here is that this is the care that all critically ill patients should receive in all hospitals in the world, regardless of where they are. It could even be pre-hospital, it could be in the emergency department, could be in an ICU, could be on the ward. And so it's really emphasizing basic, low-cost actions and treatment. So the provision of oxygen fits very nicely into this type of course. And they're developing the course and in the process of training for that. So you'll hear more about that, but it really is even more basic than some of the other educational programs. I just want to finish with talking about patient care, because that's what we really all are about. And certainly I think we have already been involved in global health for a long time, and I think one example, of course, is the Surviving Sepsis Campaign guidelines. We do know, I've been on the guidelines committee since the very beginning, we do know that our recommendations don't work necessarily in other countries, but I think what we've done with the guidelines and also the sepsis care bundles is really raise awareness, and I think that advocacy on the part of patients with sepsis has resulted in the World Health Organization finally taking it on as a project back in 2017 with their resolution, and they are continuing with that effort. Now, the other SCCM program, I think, is also really ripe for global dissemination is the ICU Liberation Campaign. And I think our specialty has really matured to the point where we can say that, yes, we save lives, but yes, our care sometimes causes harm, and we need to look at what that means for our patients long-term, long after they've left the ICU. So the ICU Liberation Campaign, as many of you know, the goal is to liberate patients from the harmful effects of an ICU stay. And if you look at the different steps in this process, many of them are easy to implement, maybe not so simple, but they are easy and can be done in many countries around the world. So I'm looking forward to that actually being hopefully an emphasis for global health as well. So thank you for letting me share my thoughts with you this evening. Thanks.
All right, so our next speaker will be Dr. M.J. Reed. Dr. Reed is a trauma surgeon and critical care physician with over 30 years of multidisciplinary critical care and general surgical experience. Dr. Reed has served as chair of the Chest Disaster and Global Health Network, as well as chair of the American College of Critical Care Credentials Committee, and she's currently a member of the SCCM Board of Regents. Welcome, Dr. Reed.
So I just want to recognize the fact that there are many in the room, Jim Geiling, maybe Randy Wax, that and as Janice said, we've been doing, and Antonio and Jorge, we've been doing this for a long time. And so I speak to you guys because this is what we do during the day. I have to thank my husband of 30 years who really helped me do this. But this is my profession, this is my passion. And so I just want to bring that passion of mine to you. I'm not as eloquent as Janice, but I wanted to just say that surgery is important, it's cost effective, and it helps the youngest of the populations that we serve. Majority of the low-income and middle low-income countries, their population is overwhelmingly below the age of 25. And so we are making a huge impact when we give to that population and to have them have safe surgery. What does it take for safe surgery? It takes skill, it takes nursing, it doesn't take much in the way of instruments, nothing fancy, right? But you have to have oxygen, and you have to have the ability to put somebody to sleep or to give them regional anesthesia. And having done surgery in at least 5 continents, it can get scary sometimes when you don't have that. So what we're doing with the AIRS project is very important. I just wanted to bring a note. This is a 2022 article by Skies et al., estimating and documenting with their calculations the preventable deaths in the first 20 years of patients if the surgical care was surged in level 1 hospitals. So for those of you who don't know, this is a level 1 hospital. This is in Bong County in 2013, right sometime after, a couple of years after the Civil War and right before Ebola. And this is a hospital that, as John said, could have electricity 6 hours a day, Monday through Friday. All right, so surgery was very limited. Again, this is the inside of a level 1 hospital. This is in Tanzania, Tanzania. And as you can see, it's pretty sparse, and they had a World War II level anesthesia machine. So what this is showing is that they looked at appendicitis, obstruction, and as 2 of the gastrointestinal. They also looked at trauma and surging the level 1 hospitals, which are essentially emergency rooms with some skill sets, and giving them the ability to do somewhat advanced surgery. Usually they're staffed by registrar level, resident level, or just out of their residency medical school surgeons. They learned very quickly. This gentleman, Dr. Julian, was 2 years out of a combined a 6-year medical school. But what this shows is that by giving them the tools and surging up, that they actually decreased and prevented at least 300,000 deaths in this age population, mostly from maternal and infant peripartum mortality, maternal hemorrhage, asphyxia, and then between the ages of 5 and 25, it was mostly trauma. So this is definitely a worthwhile investment, because if you save the children, you save the next generation of working lives of the GDP of that country. Okay, so it's extremely important, not only for the kids that you see, but also to save the countries and make them better places and bring them up in economic development. So that's really my story, and the biggest thing I want to say, I'm perfectly on time, I love that, my God. What I like to say is this is my aha moment. For Vinjay, who said, where's your aha moment? These are my moments, right? And so I'd like to leave you there with those faces of wonderful kids and all. Thank you guys very much.
Thank you, Dr. Reed. Our next speaker will be Dr. Anna Crawford, who is an associate professor of anesthesiology and critical care medicine at Stanford University. She founded the Division of Global Health Equity in her department and serves as the director of global engagement strategy. Dr. Crawford is also the creator and editor-in-chief of the online open-source Global Anesthesia and Critical Care Learning Resource Center, which has reached over 8,000 learners in 145 different countries. Please welcome Dr. Crawford.
I think my fans are here. Thank Thank you. Thank you. It's really great to follow Dr. Zimmerman and Reed because there's a lot of overlap, so that makes my talk shorter, but I think it also means we're on the right track and we're looking at the right things. So I'm an anesthesiologist, but I just want to take a step back because I think when it comes to critical care, we're all in the same game together. We've already talked about the big differences when we talk about critical care. A lot of us might think that it takes an ICU filled with high technology and highly trained specialists. But critical illness happens everywhere, so we really need to think about critical care as happening anywhere our patients get critically ill. So when you think about critical care as ICU level care in a lot of countries that don't have very many resources, it gets easily dismissed. And so critical care has been largely under prioritized for way too long. You guys have already seen this contrasting type picture, but when you're a patient and you're critically ill or ill at all, you assume you can walk into a healthcare facility. You can assume that somebody's going to take a physical exam and take some vital signs and come up with a care plan, and then you're going to be triaged appropriately to where you can get that care. Unfortunately, in many of the places that we're familiar and that we work, you may or may not get your vital signs checked. You may have your vital signs checked on admission, but then never again through your entire hospital stay. You may not receive the attention of others unless your family member who's at bedside flags another provider. Unfortunately, a lot of our colleagues may not actually know what to do with those abnormal vital signs. So if we're talking about advancing critical care on a global capacity, we really need to take a step back and really broaden our scope outside of the intensive care unit. So when you think about our patients are much younger, we think about this could be just checking vital signs. This could be very simple medications like essential oxygen, which unfortunately wasn't even determined an essential medication until 2017, which we all know is way too late. It really is cost effective. So critical care doesn't require ECMO. Most of us who are working in critical care realize that our burden of critical illness is we think it's increasing. It's also inherently difficult to measure because just because you don't have an ICU doesn't mean you don't have critical illness. So the burden is difficult to measure, but it happens in all different types of patients, all different locations. It can happen in the ward, it can happen in maternity, it can happen on the street. So the burden of critical illness is difficult to really measure, especially in these places where we have a paucity of data. We have aging populations, pandemics, epidemics, climate change, et cetera. We also, as we advance our care, we're going to have more and more complications of advanced level care. So all of this is really increasing this critical care burden. So something we need to really pay attention to. Thank you, Dr. Zimmerman, for mentioning EECC. I have a disclosure. I'm actually the head of their training group, so working with them very closely. And just want to spend a minute here with EECC because it goes back to my point that we're not really looking for ECMO machines here. What we're looking for is any critically ill patient is recognized and receives the very first step of intervention. So this group has done some really amazing work. I'm just starting to work with them over the last year or so, but primarily, as I mentioned, when you come in and you're critically ill, your hospital system has to recognize you and then do the first step intervention. So the things we're looking for are nurses trained to read the vital signs, protocols for checking the vital signs. Oh, by the way, we need a pulse oximeter and a blood pressure cuff as well. And then the hospital processes, the hospital readiness and then clinical processes to appropriately address that. So these are very simple, cost-effective interventions. It's the oxygen that Dr. Sampson's been working on. It's the intravenous fluids. It's the insulin. It's the very, very simple first steps that we all definitely take for granted, but unfortunately are not present in most of these places. I'm not sure why it's not advancing. Oh, there he is. Okay. So this is a good friend of mine, Farai Matsimbamuto. I met him in Zimbabwe. He is actually now in Botswana. And in the middle of the pandemic, thank goodness for Farai, he's very outspoken. And he basically shouted from Botswana and said, stop sending us ventilators. We don't even have oxygen and electricity. So his call in this paper is basically stop our obsession with new technologies and advancing technology when we don't even have the basic infrastructure upon which to build. Eventually, we do need an ICU. So we need to expand our ICU bed capacity, but we need to do it in the right places at the right time. Not every place is ready for an ICU bed. So in those places, we really need to start with essentials. But eventually, we do need intensive care units. The number of beds, as you can see in the map, places like high-income countries, the United States and Europe, we have sometimes 25 beds per 100,000 population, where many places in Africa and Southeast Asia have 0 or less than 1. So eventually we do need to expand our ICU bed capacity. But we also need to recognize that, for example, in the United States, we have way too many resources that we don't use appropriately. So I think we also have to look at the high-income countries and make sure we're utilizing our resources in a socially justice, economic type way, because more resources do not always improve outcomes. As you guys probably all realize, we have very poor outcomes for a high-income country on many, many different metrics. I'm going to push on us a little bit here, and you can see I'm guilty. I'm in this group of people, but short courses are fantastic. They're really great for refreshers. They're great for CME or CPD. They're really good for helping your colleagues address COVID, but they don't really expand critical care capacity in a sustainable way. So we really need to help our colleagues develop ICU training programs for nurses and physicians. We need to work across our societies to really build sustainable impact in education. I'm going to skip through this. This is basically what Dr. Zimmerman said. Our colleagues are not really asking for technology. They're asking for access to our conferences. They're asking for access to research projects. They're asking for mentorship and education and training again. So we need to ask them what they need. I really want to commend the SCCM and specifically John Sampson for bringing all of the specialties together, because when it comes to critical care and you're in a low resource setting, you don't have the luxury, it's really a luxury to approach it from the silos of different types of specialties, because a lot of places don't even have specialty training programs, not to mention subspecialty training programs. So really we need to work together and collaborate to expand critical care capacity. A few priorities and solutions I would like for SCCM Global Health to consider is really working on essentials, so the EECC infrastructure and the quality of care. One remarkable statistic, it comes out of the African surgical outcome study, where if you're a patient in Africa, you are 50% more likely to die the day after surgery. 50% more likely. So it's not just an access to care, it's also a quality of care. So we really need to make sure that we're measuring the right things, which is how our patients are doing. We need to train the workforce, advocacy. I would encourage SCCM to work across all the societies. There's a lot of great things going on, and there's no reason to recreate wheels, and just continue to advocate across those societies. So, thank you.
All right, our next speaker is Dr. Ramon Gist, who is an assistant professor of pediatrics and the director of pediatric critical care medicine at SUNY Downstate Health Sciences University. Dr. Gist is an expert in disaster management, academic international medicine, and justice, equity, diversity, and inclusion initiatives. Please join me in welcoming Dr. Gist.
All right, thank you so much for that introduction. Tonight, I hope to show you how pediatrics intersects with this initiative of surgery obstetrics, trauma, and anesthesia. Not a big deal, right? Not a small task. So I want to keep it basic. So many people think about pediatrics and global health. They think about, how do we increase food supplies, access to clean water, vaccination campaigns, treating dysentery. But when you look at the stats from the WHO for the last 30 years, mortality has decreased from these causes by about 50%. However, the current stats will show you how and why this initiative is so important and relevant to pediatrics. If you look at children under 5, the leading cause of death is birth complications, right? And here in the US and the West, we take for granted that at every birth there's a practitioner readily available to deliver care to a neonate. Also, we have standards for which someone has to be present in advance in the delivery room for these births. but across lower and middle income countries, this is not a resource that's readily available, right? And so thinking about obstetrics, thinking about anesthesia, we have to have providers trained in pediatric resuscitation in these settings, because having access to separate providers who can do that service is a luxury. Then looking at folks over the age of 5, leading cause of death is what? Injuries, right? So injuries being gunshots, assaults, stabbings, right? Accidents, trauma, falls, drowning. We take it for granted here that we have immediate access to PICUs, SICUs, where folks can receive life-saving interventions, right? But the best available data in low and middle income countries shows that only about 40% of countries have a single ICU, right? And that single ICU is located in the central center. That means that children who live in rural areas have no access to pediatric intensive care services. Then looking at pre-hospital services. So the folks who live in those urban centers where there is an ICU that you may or may not have access to, how do they get there? In the West, we take it for granted that when you have an accident, you have access to EMS services, ALS, PLS providers who can sustain you until you get to the ED and the ICU, right? But oftentimes in developing countries, we don't have access to those resources. So clearly, we can see through the leading causes of death that we have for children under 5 and over 5, how this effort is truly important for pediatrics and how pediatrics is essential to this effort. In 2014, the Task Force for Mass Critical Care recommended that pediatrics no longer should be considered a special population, because pediatrics is so essential to care across all continuum and all specialties. So for this initiative, this global health initiative, we have to also remember that pediatrics has to be considered in all aspects of this endeavor. Lastly, we have to keep an eye on equity, right? When we look at who bears the burden of mortality in these statistics, it's sub-Saharan African countries, as we had mentioned earlier, and also South Asian countries. So when you go to these, to these countries and you work with folks who are providers there, it's not an issue of knowledge, it's not an issue of, lack of will. It's all about systems, as we heard mentioned before, access to systems that can actually provide this level of care. And so it's important that in these endeavors, we focus on empowering those who are doing the work, who have the cultural currency with those who live in their communities, to get this new technology to be accepted to those who they're caring for, and also to those who they have to advocate to get funding and buy-in those communities. We must get away from the old school style of colonial approach and mission-based care and focus on empowering communities. Thank you so much.
Thank you. Our final presenter of this section will be Dr. Rebecca Silvers, who's the director of the University of California, San Francisco Center for Global Nursing. Dr. Silvers is also a nurse practitioner at Benioff Children's Hospitals in neurosurgery and critical care, and is the nursing lead for the World Health Organization Collaborating Center for Emergency, Critical, and Operative Care. Please join me in welcoming Dr. Silvers.
Hi, everybody. So glad I made it after 13 hours in the ICU, and everybody looks great. Okay, it was a great day. I'm so excited when John asked me to come speak with you all, because any chance to talk about nursing and global health, I am thrilled. I have been a nurse for more than 20 years and have worked in more than 15 countries setting up pediatric critical care. And I have so much to say. Oh no, this is my life passion, and being amongst these people just makes me the happiest. So I left my job with Lauren Source to go work for PIH because I couldn't turn it down. But now I'm here at UCSF, and everybody here knows, because you work in critical care, how essential nurses are in our care that we provide our patients. But beyond care, they're thinkers, they're innovators, and they need to be a part of all the solutions that we are creating together as a team. They need to be a part of all of the work that we're doing across the globe. But if I backtrack and I think about critical care nursing, in all countries around the world, and I've studied this for a bit of time. It's so interesting to think about how lucky we are at UCSF, how the nurses that I work with every single day have the luxury of training, education, and an opportunity to learn specialized skills to provide this care to our patient. And when we think about what is the global standard for critical care education for nursing, we recognize that it's not what we want it to be, and that in so many countries around the world, nurses have just a technical training that are working in an ICU and taking care of critically ill patients. So technical training, for those of you that don't know, this is skill-based training. They're not being taught critical care. They're not being taught how to mix medications and provide inotropic support. They're not being told how to check a blood pressure and know if it's normal or abnormal. They don't have these skills, and that's one of my life's passions, to kind of help improve that and, and improve quality of education, training, and nursing. I'm so lucky to have found a home at UCSF where I've been working with many interdisciplinary teams on a lot of nursing education. When COVID-19 happened, we all had this huge need for remote, urgent information training available for all cadres, for nurses, for doctors, for anesthetists in low and middle income countries. How can we support them through this time? So we opened this project, and we didn't just write stuff, there's so much good stuff out there. So what did we do? We took the amazing National Institute of Health video in London on, I think it was assessing the critically ill patient, and the AACN's video on proning, and we put this all together to share with our partners who had ventilators they didn't know what to do with, and high flow oxygen, and they're like, how do we titrate this? And our goal was to make free resources available for all. It still lives online and is used by so many. We have tools, training, guidelines, protocols, but it was amazing that they thought, hey, let's get nursing involved in this. Hey, let's make sure that they have a voice. I'm so excited to be a part of the WHO Collaborating Center for Emergency, Critical, and Operative Care, and have been fortunate enough to collaborate with them on all the toolkits. It's important that we think about nursing when we think about education, because we know what they have learned and we know where we need to go with that. So it's exciting I'm excited to be the nursing lead and continue to advocate for nursing being involved in the new critical care curriculums and all the tools being provided. As I mentioned, I'm really into policy and advocacy and relating to nursing education and getting involved in critical care and surgical services. And so I'm working with the Global Neurosurgery Consortium and many members of the pediatric critical care world in cardiac surgery and saying, actually, can we get more data? Because we don't have a lot of data of what our nurses working in critical care, what did they learn in school? What did they get for on-the-job training? So we're kind of trying to gather some of that. And then I'm also interested in kind of educational design, and I think we should all be thinking about this. With COVID, we all learned a lot about remote teaching, remote training, empowerment. And so I'm working with a hospital in Ghana and an amazing team at Yale. They're just doing amazing work to try to figure out how we can study distance curriculum and virtual simulation, and does this help? Because as we set up oxygen ecosystems, which is the foundation, how can we build those sustainable programs? How can we educate long-term? How can we help them problem solve after they have this patient or that patient? Should we have case conferences? What does that look like? And then one of my favorite nursing places and stories is this hospital in northern Laos, where I'm working with actually a member of the G4 Alliance on a lot of quality improvement projects. But we had nurses that were all new graduates when we opened this pediatric hospital in 2015 or 16. And now they're nursing leaders. They're running education programs. We've opened an intensive care unit. We have an operating room run by CRNAs, which is pretty amazing. It was cost effective for them to train nurses. And so it's amazing to see what education, focus on sustainability, and teamwork can really do. And last thing, I just want to share about our new center at UCSF that I'm excited to be the founding director. I said, I have an idea. So this is good. So we're building this new program. It's focused on education, service, and scholarship. We basically have a problem in the US with nursing in that our training is it's quick. We have to get our competencies and get into the workforce compared to our physicians that have very long trainings and opportunities to explore global health. But we need nurses with clinical skills to work in global health, to mentor, to train, to be a part of our solution. So how do we do that? We have to create pathways for them. We have to create support. I quit jobs so many times just to do global health, and that shouldn't be the thing. So our big goal is to bring our scholars, our global health leaders at UCSF, and everybody together so that we can support collaborative efforts, so that we can be a part of amazing work in surgery and critical care all across the globe. And I'm just excited for all of you for supporting nursing and for being a part of our team, and look forward to working with everyone. Thanks.
All right, well, I'd like you to all give a huge round of applause to our amazing presenters who just packed in so much information and stuck to time. Thank you. And now I'm going to just turn it back over to Dr. Sampson for some closing thoughts, and he's going to then transition us into our next session on global health technologies.
Well, these were all great speakers, and they accomplished exactly the goal that I wanted them to do, which was to bring together internal medicine, surgery trauma, to bring together pediatrics, to bring together anesthesia, and to bring together nursing, all different aspects of the multidisciplinary nature of the Society of Critical Care Medicine, so that we can actually see that all of these tie together with one of the most underserved aspects of critical care medicine, which is related to surgery, obstetric trauma, and anesthesia, SOTA care. This is essential. And I really don't have anything else to add other than what these wonderful speakers have already said in regards to the need for all of us to get together to help to solve these global health disparities. And I would like a round of applause for all of our speakers. Thank you. So now we're going to get into our global innovative technology section. And the one thing that binds together the three technologies that we're going to be featuring is that they're all environmentally friendly approaches to global health from a technology standpoint. And so the first speaker, we're going to bring back Dr. Jose Gomez-Diaz, and he's actually going to talk about the butterfly ultrasound and how the butterfly ultrasound is a very innovative global health technology that is also environmentally friendly. Okay.
So Dr. Jose Diaz-Gomez is the Section Chief for Cardiovascular, MCS, and Transplant Critical Care, the Anesthesia Critical Care Medicine Fellowship Program Director, and the Director of Critical Care Echocardiography at the Texas Heart Institute at Baylor St. Luke Medical Center. Dr. Diaz-Gomez will be presenting the butterfly ultrasound. Welcome, Dr. Diaz-Gomez.
Thank you. It's so nice to start saying that, yeah, it's correct. It's an environmental friendly technology. So SCCM has a very clear ambition future. And you can see in that slide, we really want that integrated team dedicated, trained intensivists and critical care specialists. And we really want to have that equitable patient-centered care. So I have an inspiration today. There is no other tool with the highest value to really embrace equality than POCUS. I can be in Rwanda, I can be in Ghana with you, or I can be at Texas Heart, and I still will be making the same diagnosis with this wonderful tool. So I have the honor to have this review article last year in New England Journal of Medicine, and as you can see, we said that in 2019 that one of the main things was we have an improved, lower cost handheld ultrasound systems. So in the past, you have on one stream capability, on the other stream was portability. Now capability is migrating to portability. So we are empowering our clinicians at the bedside to use the tool correctly. And you can see here There are several handheld ultrasound systems that can perform more measurements, analytics, quantification. That's better patient care right away at the front line. So I've been working, developing now even a pulse wave Doppler-driven approach to undifferentiating shock. So a clinician in Africa or Asia can be at the bedside without having a cardiologist, and then now able to really have a good differential while your patient is hypotensive, quantitatively. So we take things seriously. This is our headquarters in Chicago for the SCCM Council, and you can see there many of our wonderful leaders. And I just want to show you how the program of ultrasonography within the SCCM has been really expanding, growing. Now it has proven to be successful, is institutionalized. We have wonderful support from the SCCM staff, and then our goals are actually to teach others, so train the trainer. We're going to Ukraine, but I'm telling you, in 1 year there will be some expert from Ukraine that might be here speaking at our annual Congress because of what we have learned. We maintain a high quality programs, and we take that seriously. Every 6 months, we have a packed room, like you're seeing in this slide. It's real. I call Teresa Wiki 1 month ahead of time, sold out, Jose. Sometimes I have to call and say, can you put somebody else who's contacting me? That's a reality. We now even offer to any hospital in America, you want to bring the ultrasound course to your hospital? We're there for you. We are very organized. You can see in this slide, this is the critical care ultrasound committee. It's not like you will be there forever. I was there like probably 5, 6 years ago. Now's the time for the new leaders. But we standardize the curriculum. It's not like a Jose Diaz Gomez want to do this kind of revision. No, it has to go through the committee. It's real democracy there. So we offer these in-person skill courses. We do for adults, neonatal, and an adult, and it has been even better and better. This is a tweet I sent 2 days ago. These are our statistics. You can see in 2023, so after the pandemic, we became stronger, and it should be 240 attendees. This past week, we trained them. It's a smart course. We implement a course that actually it makes more emphasis on hand-on training, and the person actually has been already received the lectures online. We have a wonderful test book. We bring experts from different disciplines, different parts of the United States and even North America. And you can see here, all our cases have the whole wide breadth of critical illness. I have a distinct honor to be the editor of the ultrasound test book. And I did not know that the society translated to Spanish. So I'm walking in a room in Peru, and I see, when they translated this? So I have it now in Spanish. I never imagined when I went to my medical school that society will be published a book in my native language. We have been present internationally, nationally, you can see there, all these countries, but there was a special one, Hospital San Salvador. This doctor looks very young, but she's the CEO of the hospital. And she has one of the ultrasound devices, and this hospital is important because during COVID, they transformed a convention center into a hospital of 1,000 beds. So there was a tremendous value for the SCCM for the first time delivering that course in Latin America. We did it. SCCM is careful about relationships. Here you have a picture of me with the current president of the American side of echocardiography. We want credibility. We want the cardiologists to respect us as well. So I go there. We go by high standards. And now with the presence, I want to really applaud for Dr. Nikravan, who is my vice co-chair, my co-chair for the ultrasound guidelines. You can see how diverse we are. And that slide says a lot. You see on the right, we have 14 different backgrounds in a panel of 24 people. We do this by merit, not just to look that we look just different physically. And I'm very serious about that. So the guidelines will be published hopefully within a year. And lastly, we cannot do this job without the help of our SCCM staff, like Teresa Wilkie. She's not here. She's tired in working so hard. Lastly, I will tell you, I'm immensely grateful to the society. I've been in all these institutions, but since I was a child, my parents believed I was going to be a doctor. That's the reason that was my first costume in a Halloween. But I need to put SCCM on top of all the hospital I have worked for, because without the society, I wouldn't be the person who I am today. Thank you.
Next, I would like to introduce Francois Lacombe, who's the CEO of PCI Gases. Mr. Lacombe has extensive experience in senior management positions and expertise in international strategic business development, plan execution, aftermarket services, supply chain operations, sales, and marketing strategies. He will be sharing PCI Gases' innovative vacuum swing absorption, or VSA technology. Please welcome Mr. Lacombe.
Good evening, everybody. This is the non-doctor part of this conference. I'm not a doctor, and it's a little intimidating to be following so many talented and smart people. So I'm going to try to appear smart. Just a few words about PCI Gases. We are a mid-sized company, 60 million in revenue. We are headquartered near Los Angeles in Riverside. And we have roughly 200 employees, 100 in the US, and then we have a plant in Brazil, in Curitiba, and one in India, in Bangalore. And I will explain why we have those two plants overseas. PCI was created about 30 years ago, mainly to work on Department of Defense program. We develop liquid oxygen and liquid nitrogen plant for them. And then, as you can see, one of the programs that we worked on was military medical oxygen. We developed a product that had to be ruggedized, that had to be deployable in the theater of operation anywhere in the world. And after a few years, we realized that that product that we had developed and that technology that we had developed could also be, of course, used for commercial oxygen, but more specifically medical oxygen. As an executive, I worked for many companies, and it's contrary to what you live every day, it's difficult to find a purpose. But I have to say, collaborating with people like Dr. Sampson, and he visited us last week, is really a privilege, and I want to thank you, Dr. Sampson, for inviting me tonight. So we have developed a technology that is slightly different from the conventional way we use and concentrate oxygen. Oxygen is everywhere. Oxygen is life. And oxygen doesn't cost anything, but separating oxygen from nitrogen is very costly and very environmental unfriendly, I should say. Why? Because it takes a lot of energy to separate and concentrate oxygen. So this is, and when you are in hospital, you have a choice. You either buy liquid oxygen that has to come, on a truck. Liquid oxygen is even, less environmental friendly because you need to, cryo-freeze the oxygen, and then the truck that brings you the oxygen is also, a diesel engine or not very friendly. And what we have developed is a much simpler solution, actually, where you don't need an air compressor. You just need to blow air into a tank that is full of molecular sieve that separates nitrogen from oxygen. And as you can see, it's a self-contained unit that is built on a skid, so it can be moved and deployed fairly easily. This product that you see here is a DOX 500, so it produces 500 liters per minute of oxygen. And we have a range of product from 80 liter per minute to 500 liter per minute. So I'm not going to spend too much time on this slide, but basically our technology, which use vacuum swing as opposed to pressure swing, help us to develop a simple solution with less valve, less moving parts, so it lasts longer, it is easier to maintain, but also more importantly, we do not use any compressors, so there is no risk of oil contamination in the oxygen that we produce. Talking about power consumption, we use roughly almost 1/3, less than half of the power needed to produce a cubic meter of oxygen than any other competitive technology out there. So this is why, because like I said, we have no compressor, we have less components, less valves. It's a simpler product, easier to maintain. So what is the advantage of VSA technology versus PSA technology? It is, like I said, very robust, and the fact that we developed those products initially for the Department of Defense means that in our DNA we always try to develop products that are easy to deploy, easy to use, and easy to maintain. We mentioned already the low running cost. We take about half the size of a PSA unit. So real estate is premium in an hospital. It's also premium, I would say, if you're being deployed in the middle of nowhere for relief missions, for instance. So that's a very important benefit. Oil-free, I mentioned, and energy consumption reduced by 50%. Another very important point is that our technology works regardless of the altitude. And if you are in Bogota, for instance, and you're in an hospital in Colombia, that has a huge impact. So our technology is completely immune to the high altitude performance issue. This is something that we've been discussing with Dr. Sampson. We are developing a new version of our smaller oxygen concentrator, the DOX 80, and the idea would be to have a self-contained, completely independent of any other source of energy unit that can be deployed even in places and countries where electricity is there 2 hours a day, you mentioned, Dr. Sampson. So it's really something that requires a lot of R&D from our side. From our side, we committed to Dr. Sampson to have a prototype by the end of Q2. So the timeline is really short. Right now, we can power our smaller unit, the DOX 80, during the day, and for roughly 4 hours at night. We are limited by batteries and how much batteries we can put into this self-contained container that has our product inside, but it might be necessary to add additional solar panel outside of the container. But the prototype that we're currently developing would be completely self-contained in a 20-foot container. So talking about environmental friendly, I don't think you can do any better than having a fully solar-powered oxygen concentrator. Even if we have to use power, it is electricity because contrary to PSA technology that usually uses diesel engine to power the generator, but also the unit, we use mainly electrical engines, which are more environmental friendly. So I mentioned we have three type of products. Only the smallest one is currently the subject of our research and development effort to be fully powered by solar power. But obviously, depending on the need of the hospitals, we can produce anything between 80 liter per minute to 500. We have also much larger oxygen concentrator, but they are used for smelters, for instance, for industrial application. But medical oxygen is more than 50% of what we do and will continue to be the focus of our development. Now, if you look at where we've sold and installed our medical installation, that's all the green dots that you see on this chart, and you will see that there are very, very few green spots in North America, and the reason for that is that we produce oxygen at 93% plus minus, which is not recognized as medical oxygen in North America, even though it is everywhere else in the world, and the WHO is also recognizing 93% concentration as being a valid medical oxygen solution. I don't know if I appeared smart, but I did it in less than 8 minutes, so thank you very much.
Our next presenter will be Dr. James Bernstein, who's the co-founder and CEO of Anywhere LLC. He's a healthcare entrepreneur with over 40 years of experience in medicine, government, and business.
Good afternoon. I'm James Bernstein. I'm the CEO of Anywhere, and it gives me great pleasure to be joining.
Since founding Anywhere, Dr. Bernstein has become a vocal advocate for increased access to safe, essential surgery worldwide, and is a speaker at international academic conferences devoted to global surgery. Dr. Bernstein has prepared a video for us on the Anywhere technology for surgical sterilization, and I will go ahead and play the video now.
Good afternoon. I'm James Bernstein. I'm the CEO of Anywhere, and it gives me great pleasure to be joining you by video in San Francisco this afternoon. I've been asked to speak to you about our environmentally friendly portable surgical instrument sterilizer that uses no heat, no water, and most of all, no electricity, and will be able to make essential surgery possible anywhere. Essential surgery requires three pieces. It needs trained people. It needs anesthesia. It needs trained anesthesiologists. And then it needs sterile surgical instruments. Both anesthesia and sterilization are dependent on electricity, which is, as you know, in short supply all over the world. If you don't have essential surgery, bad things happen. And I'm going to give you two examples just to alert you why this is so important. Number one, if you have a C-section where there's no sterile instruments, you often get sepsis. This is a lady who died 9 days after her C-section from sepsis. Or if you can't get a C-section because there are no sterile instruments, then you're apt to get a fistula if you have obstructed labor. Both of them totally unnecessary in today's world. The lack of electricity also impacts critical care. Again, in all those parts of the world where electricity is in scarce supply. I want you to compare a birthing suite in a US hospital to a birthing suite in sub-Saharan Africa. No electricity, 2 lanterns, and a kerosene stove to boil water to sterilize instruments. Of course, we know that boiling water does not sterilize instruments. Or if you have an autoclave like the one over here, you notice it has a wire that's supposed to plug into an electrical outlet. But if there's no electricity, that doesn't get the job done. Modern autoclaves, the ones you use in your hospitals, are totally not designed for the developing world. They break, they're not maintained, they look like the picture on the right. So now the Anywhere Portable Sterilizer. This sterilizer is portable, weighs 25 pounds. Its cycle will be slightly over 2 hours, very comparable to an autoclave. It runs at room temperature. It uses no electricity or water. It uses 2 landfill-safe consumables. It uses nitrogen dioxide as a sterilant gas. It sterilizes to a PNSU of 10 to the minus 6. Its software controls manage all of the cycles and the safety controls and interlocks. And it's easy to use, easy to learn, and most of all, it's inexpensive and environmentally very, very friendly. So how does nitrogen dioxide work as a sterilant gas? I don't want to go into all the details, although some of you may have a bigger interest in it than others. The important thing is that it works by disrupting DNA and RNA, by damaging the strands in an irreversible way. Most of you probably are familiar with the fact that white blood cells, leukocytes and monocytes, make NO, which combines with oxygen to produce NO2 in vivo. That's how white blood cells combat infection. If we take NO2 in vitro, it combines with water and goes through the walls of spores very quickly, combines with guanine and cytosine, damages the DNA and RNA. So when we're building a portable sterilizer, we have to make sure that we have adequate humidity, and we have to be able to demonstrate that it kills. The Anywhere Portable Sterilizer is very environmentally friendly. It's effective in very low doses of NO2. It's non-explosive, non-flammable like ethylene oxides. It can be rapidly removed by a very simple proprietary scrubber that's landfill safe. It uses no electricity or water. It has no residual cytotoxicity. It has a broad material compatibility. So we had our first Anywhere sterilizer, which we took to Sierra Leone with Dr. Sampson several years ago. We got substantial user feedback both from that trip and also from the military, who had our sterilizers for over a year, trying them out on austere environments. Their analysis was very positive, but they had some suggestions to make. Nobody likes the cycle time of 4 hours, it's too long. The surface-mounted control bezel and the activation handle, which had to be twisted, prevented easy stacking and it was very difficult to turn. The consumables contained hazardous substances, nitric acid, for example. They were glass. They were hard to use. The scrubber was in 2 pieces, and because of the nature of the consumables, they were expensive to manufacture. So we had to fix this, and we had some substantial problems to solve. We had to come up with new gas generation chemistry that was non-hazardous, with easily available materials, landfill safe and inexpensive. We had to learn to scrub much faster, also in a single cartridge, also inexpensively, and we had to shorten the cycle time and the scrubbing time, and we had to be able to validate all of this with self-contained biological indicators. So this is what we've developed. We have a large but portable case. You can see the dimensions here. The internal sterilization chamber is 25 liters. The whole case weighs 25 pounds. The sterilization chamber will fit 2 full-size surgical instrument trays. You'll notice that when you open up the case, inside is the instrument case. In the front are all the places you put in the scrubber and the gas generation cartridge. All of the mechanics are there. Very simple to use, very accessible. The cover closes with 2 very, very easy to use latches. The consumables are landfill safe, inexpensive to make. They're not fragile, and they can be shipped anywhere in the world without any restrictions. So how does it work? You turn it on by pressing the button. You insert the 2 cartridges. You put the instruments in the tray. You close the case. You press the button to start, and you wait until it's over, and you're done. So the 2 components which you may be interested in are the sterilization cartridge that has the gas, NO2, it generates it, and the scrubber is also a cartridge which is easy to use. The sterilization cycle is just under 2 hours. The scrubbing cycle is very fast, and this can be used 4 degrees to 40 degrees. So, in closing, just to make the point, this is a very, very important, innovative, environmentally sound technology whose importance was brought home to me yesterday. The Wall Street Journal had a letter from the mayor of Kyiv. This is what he said. And he said, we need help for our doctors so they can perform surgery when there is a lack of electricity. This problem exists worldwide. And our sterilizer, our environmentally friendly sterilizer, can solve that problem by sterilizing instruments without heat, without electricity, without water, in timelines that are completely comparable with autoclaves. So thank you very much for tuning in, and we look forward to interacting with as many of you as are interested in what we're doing.
Our final presentation will be from Alan Tratner, who helped establish the first Earth Day and contributed to the first International United Nations Conference on the Human Environment in Stockholm, Sweden in 1972. Mr. Tratner is an inventor, social entrepreneur, and a nonprofit leader whose organization, the Environmental Education Group, and its project Green to Gold focuses on sustainable economic development. And Alan has also prepared a video for us.
Greetings, fellow Earthlings, and many thanks to IGPC, G4 Alliances, and SCCM. And we are proud to assist the multiple major hospitals across 3 African countries that Dr. Sampson's team is helping. We just heard presentations on 3 innovative, energy-efficient, and green medical technologies that are part of this effort: the butterfly ultrasound, the vacuum swing oxygen, and the Anywhere. Most ultrasound machines are large, massive devices with huge screens and multiple probes that can only be used for specific types of examination. The butterfly ultrasound device is a handheld device that can be carried in a physician's pocket and uses microprocessors to simulate many different types of ultrasound probes. Thus, it can examine the heart, chest, a fetus, veins, arteries, lungs, nerves, etc., with one small pocket rechargeable device. PCI gases, vacuum swing oxygen devices, are the only oxygen generation technology that uses 50% of the energy requirements of all other types of oxygen generation. Because of this, the company is now working on selling it as a package with solar energy as its sole power source. Dr. Bernstein's marvelous Anywhere sterilization system does not require electricity or an autoclave for high-level sterilization of surgical instruments. I am Professor Alan Tratner. I helped establish Earth Day in 1970, and on that occasion launched the pioneering environmental education group and the Green to Gold nonprofit, the first global impact incubator for green tech, invention, entrepreneurship, and socially and environmentally responsible nonprofits. The medical world has a wonderful oath that focuses on do no harm, and many practitioners, including veterinarians, maintain it also means do no harm to our life-sustaining planet for a whole host of critical reasons. Green to Gold embraces this fully, and we created the National Transition Initiative, supported by the White House, the resilience element of the insurance industry, as well as many other entities, utilizing the brilliance of our worldwide membership to help institutions and facilities of all types to transition to and adopt natural, safe, abundant, renewable energies, such as solar and wind and geothermal, bio-based fuels, microhydro, energy and water efficiency, waste reductions of all types, non-toxic building materials, etc., to foster the global, inclusive, green economy for harmony, balance, and sustainable economic development in our world. These elements dramatically reduce pollution of all types. They make for healthier indoor and outdoor environments. They mitigate climate change, and as a bonus can save you costs, make you more reliable, available, and resilient to natural disasters that are breaking records across the globe, and reduce negative environmental effects on your patients, pets, animals, and plants. Our transition project affords the medical world a vast 53 years of world-class expertise in turnkey advanced products, techniques, and services. This is part of the force and resources that we bring to the African projects and offer to all of you in medicine. Green to Gold also has projects in Georgia, Illinois, where we are doing a pet and animal hospital and dog daycare center, Colorado, California, and Hawaii. Aloha. From the most advanced, safest, productive, smart solar electricity panels to harm-free, bio-based, non-toxic, safe disinfectants for humans, pets, and plants, and everything in between, from super efficient heat pumps, regenerative agriculture, revolutionary bio-based compostable packaging, a virtual cornucopia of effective solutions. Happy, safe, healthy, prosperous, and sustainable, impactful New Year to all, and thank you.
Well, Professor Tratner wasn't here, but I couldn't have asked for a better wrap-up. I think he did a really great job. I was going to emphasize some of the same things that he said as if he was here, right here today with us. So we really appreciate all of you coming here tonight to help us to celebrate the new initiation of SCCM Global Health. We would like to thank the SCCM for developing global health. We would like to thank the sponsor for really helping to start SCCM Global Health as well, the representatives from Direct Relief. If you could stand, okay. Thank you. Thank you. And so we'd like to thank everyone for coming and enjoying this time with us. And I want to encourage everyone, we have a great panel of technological innovators, some great speakers here, leaders in different aspects of critical care, global health critical care, and I encourage you to spend a little bit of time to just interact, get to know each other, and talk about where we can take SCCM Global Health for the future. Thank you.